Going to do the second part of the updates, critical care updates would be mechanical ventilation ARDS. We're going to go over the trials of automated closed looped ventilation, active investigators. We'll go over proportional assist ventilation. What does all that mean? We're going to go over oxygen therapy and mechanically ventilated, what goals, steroids and pneumonia and ARDS, the CSAR randomized trial, update on ARDS, a new global definition, hot COVID, and again, oxygen targets machine learning, neuromuscular blockade at ARDS, and electrical impedance tomography, high flow or standard oxygen, acute hypoxic respiratory failure. We'll go over non-invasive respiratory support guidelines, and then oxygen therapy for cardiac arrest, and then hypertonic saline versus carbocysteine for acute respiratory failure. Before starting, this is a nice review of ventilator basics, beyond the basics, and then the ventilator concepts if you want to review that. But what is adaptive support ventilation before we see some of the newer articles? It's a closed loop dual control mode. What does that mean? You set a weight and a target minute ventilation. So instead of like on assist control ventilation, you set a rate and a tidal volume. Here you're setting a target minute ventilation. And the ventilator will continuously calculate a respiratory rate over a tidal volume combination to minimize the work of breathing. So it resolves it breath to breath, depending on the compliance, resistance. So basically, it's like an autopilot. This is basically how it looks. It's called the Otis equation. So you're trying to stay on this line, which is minute ventilation. And let's say you're up over here and your tidal volume is very high. So the machine will decrease the inspiratory pressure, and that way you could increase your respiratory rate. And then it would keep you on that curve, and that's the target tidal volume, target respiratory rate. So based on where you're at, it will change the rate and the tidal volume, so that it matches the minute ventilation. That's the bottom line. So maybe this would be beneficial for patients. So no difference in ventilator-free days at day 28, mortality, ICU length of stay, better ventilation quality, more time in the target zone, less severe hypoxemia and hypercapnia, but there was no ventilator-free day mortality benefit over conventional ventilation. So if you're asked about ASV, you know that there was a trial in JAMA 2026 showing no benefit. How does proportional assist ventilation work? What is this? So we know a pressure support. So just like assist control we use when somebody's really needing the ventilator, proportional assist ventilation, maybe that would be better than pressure support. We could think of it, delivers pressure proportional to the patient's own instantaneous effort, not a fixed pressure or volume, continuously measures flow and volume to estimate elastance and resistance, breath to breath. It seems very complicated, but basically you set a percent support. So let's say you say 60%. That means that the ventilator will supply 60% of the total work of breathing. Let's take a look at an example. So let's say the total work required to ventilate is 20. The patient would provide 8 and the ventilator would do 12. But let's say you're really weak and your effort goes up, so the total work required is 30. Then the machine will give you more, and it will give you 18. As you get stronger, the ventilator then goes down. So the difference is that pressure support will just give you 10. Let's say if you're pressure supported 10 the whole time, where proportional assist ventilation will give you more if you need more, but then give you less when you need less. So maybe that will help you get off faster. Once again, we talk about trigger, target, cycle. So trigger, patient starts the breath, target, fixed pressure above PEEP, and then cycles when you stop basically flowing air. Proportional assist ventilation is similar, trigger, target, cycle, but the target is a pressure that is proportional to the effort. Okay, so It is matched. It gives a fixed boost each breath. So I told you what it is. And then in the end, the promising trial did not show any benefit time to liberation of the ventilator using pressure support ventilation versus proportional assist ventilation. But now you know what it means. There was a little bit of less sedation use in delirium. Oxygen targets in COVID-19 respiratory failure. So you have hot COVID trial looking target PO2 greater than 60 versus greater than 90. More days alive without the ventilator support with lower target, no overall mortality benefit. Practice target SpO2 90 to 96%. So we don't have to use a higher target. Oxygen targets in mechanically ventilated patients, the UK-ROX trial. So low target versus usual care. No difference in 30 or 60-day mortality or hospital stay. Achieved the saturation only 93% versus 95%. There was a narrow separation between the arms. But basically, we individualized the saturation to 90 to 96%. So the initial Oxygen-ICU 2016 favored conservative. ICU-ROX pilot and Iconic found no mortality difference. And so now we're talking low target versus usual care. There was really no difference in 90-day mortality. Oxygen targets after cardiac arrest. You would think that a higher target might actually be worse. Maybe oxygen radicals, who knows? Randomized control trial, 1840 mechanically ventilated cardiac arrest survivors, saturation 95% versus a higher target. And they had similar functional outcomes, mortality, length of stay. No adverse events with the lower target, but so you could do SpO2 saturation 95 to 98% range after cardiac arrest. That is the Logical Investigators, New England Journal of Medicine, 2026. Machine learning model for oxygen targets. We already went over this when we discussed the sepsis, but basically maybe we should not just use one size fits all, low versus high, but maybe sepsis patients should have higher and traumatic brain injuries maybe should be lower. So 6.4% predicted absolute mortality reduction in individualized machine learning. This is not ready for prime time, but it's thought-provoking. We talked about it previously. I think we did. Maybe we didn't. So in case we didn't, this is how it looks. The blue would be patients that would benefit from a lower target. The red would be from a higher target. And I'll just read the discussion. In two temporally and geographically distinct randomized trials, patients' individual characteristics modified the effect of lower versus higher SATs on 28-day mortality. The use of lower saturation target may decrease mortality for acute brain injury, whereas use of higher SATs may decrease mortality for patients with sepsis and abnormally elevated vital signs. So this is going to may improve outcomes later on. Steroids in ARDS, another trial, Annals of Internal Medicine, short course, low dose steroids in moderate to severe ARDS, no significant increase in infections, and the relative risk was 0.77. This is the dosing is like dexamethasone, 10 milligrams for 5 days is the typical dose. Inhaled sevoflurane in ARDS was a negative trial, the CESAR trial, JAMA 2025. Sevoflurane versus propofol for sedation, and fewer ventilator-free days with sevoflurane, higher lactic acid, more acute kidney injury. Basically, don't use it. 90-day survival was lower. So that's not a good thing. So we wouldn't use that for sedation, maybe for refractory status asthmaticus only. ATS guidelines in ARDS management in the Blue Journal basically said systemic steroids are supported. early ECMO consideration, neuromuscular blockade, and severe ARDS, and avoid prolonged recruitment maneuvers. Here's what it looks like in the article. Strong recommendation against, conditional recommendation for. So neuromuscular blockade, you should know Accuracies was a positive trial, followed by a negative ROSE trial. So we don't use neuromuscular blockade in all ARDS patients, but still in very severe ARDS, we use it when your back is against the wall. A new proposed global definition of ARDS. So now we're adding ultrasound for pulmonary infiltrates. We're adding this score SpO2 SF ratio. And here is an SF ratio, for instance, of 114. That could help. And that's because you might not have the ability of having an ABG analyzer. So that's an example. Also here, let's look at this. Supplemental oxygen mask at 15 liters per minute. That would be your saturation 142. ARDS in resource limited settings. So I guess the new finding is you don't have to be intubated also to call it ARDS. Classically, you need the CPAP, but high flow nasal cannula, high flow of 40 liters would be enough to substitute for that CPAP requirement. High flow oxygen in hypoxemic respiratory failure, you would think that that would be better than low flow oxygen. Basically, we're looking in March 2026, the SOHO trial here, no reduction in 28-day mortality. There was a non-significant decrease in intubation. So that's the takeaway of that trial. The ATS guidelines and non-invasive respiratory support was published also in the Blue Journal. High flow nasal cannula recommended for acute hypoxemic respiratory failure, and IV suggested for acute hypercapnic respiratory failure, either modality reasonable for pre-oxygenation before intubation. So usually we think high flow nasal cannula for hypoxemia and non-invasive ventilator BiPAP for hypercapnia. How about mucolytics in mechanically ventilated patients? Another New England Journal of Medicine trial, 22,000 ventilated patients. Difficult to clear secretions. Should you give carbocisteine, which is sort of like mucomist, or nebulized hypertonic saline? Neither agent reduced ventilation duration. Carbocisteine increased upper GI bleeding, and the saline increased bronchoconstriction. So it's not routinely beneficial. SCCM guidelines, neuromuscular blockade and ARDS, you should reserve it for severe hypoxemia refractory to lung protective ventilation. Again, you should limit it to less than 48 hours. Know those two trials, Accuracies positive, and then the following up negative trial, the ROSE trial. And then this electrical impedance tomography, what's that? It's a bedside imaging technique using a chest electrode belt. Measures tiny changes in electrical impedance as air moves in and out of different lung regions. Generates a real-time radiation-free image of regional ventilation breath by breath, used to visualize collapse, overdistension, and recruitable lungs. So it's a real-time lung camera. It shows regions that are collapsed, overdistended, well ventilated as you adjust PEEP. So you would think that you should use an EIT-guided PEEP titration. That would help. But in the EIT vent trial, randomized 190 patients, there was a similar 28-day mortality, and it was stopped early for futility. So negative trial of electrical impedance trial. So rapid review, does ASV outperform conventional ventilation? No. You learned about Otis equation. No benefit in ventilator-free days, mortality like to stay. Promising trial, PAV versus PSV for liberation ventilation, no significant difference between modes. UK-ROX does a conservative SAT of 90% reduced mortality, no significance versus usual care, unlike the initial trials that showed benefit. SASAR trial, sevoflurane versus propofol, propofol, sevoflurane had a worse 90-day survival. Did EIT, guided PEEP titration, improve mortality? No. And hot COVID trial compared with PO2 targets? No clear mortality for the higher target. And thank you for listening.